from this day, I was lying in a hospital bed in Kerala where I fractured my entire hand. I had a messy fracture. And I stayed in hospital for 3 days where doctors worked on me for a 6-hour-long surgery. And they fixed up my entire hand with 12 screws, 2 plates. And I stayed in the hospital for about 3 days. My parents had spent about $1.5 lakh. I was privileged, so to speak. I had an amazing orthopedician who took amazing care of me. I had a really nice, clean hospital ward. I had really good post-op care. And that really inspired me to do the same, to go about trying to do my best to take care of people suffering and to join the medical system. And so I went on to do medicine. And as soon as I joined medical school, once I was an insider to the system, and that's when I started to see the disparities that exist in our medical system today. The disparities that we have today in our medical system are increasingly huge between those who can afford to pay for really good healthcare and those who cannot afford to pay for such good healthcare. People who are educated and people who are illiterate. People who come from this class and people who no longer have access to that class. So the medical system that we have was something really, really different. We had in medical school farmers who were turning up for heart surgeries, and because they couldn't, decades of their work couldn't afford to pay for that, turned away. Mothers requiring cesarean sections, but because they could not afford it, being sent back to run-down government hospitals. So the disparities that were there were really, really huge. Once it was my final year, I think I pretty much made up my mind that I was quite disillusioned with this medical care system that we have today. And I pretty much made up my mind that I did not want to be a doctor just for the rich and the privileged. I wanted to get into basic public health care to the masses, to those who do not have access to that kind of a health care. And so I chose to do the humanitarian route, choose to go into the humanitarian healthcare system. And it was in medical school my final year that I was introduced to Médecins Sans Frontières, or Doctors Without Borders. For doctors and nurses looking to get into the humanitarian healthcare system, MSF is often the first call of choice. MSF, Doctors Without Borders, is today the largest medical humanitarian organization in the world. We work in 65 countries around the world with about 20,000 doctors and nurses. And at the core of what we do is to take healthcare to remote conflict or otherwise excluded systems. So people who otherwise have no access to healthcare or for some reason or the other are excluded from our healthcare system, that's the people that MSF addresses. And I joined MSF 4 years ago. And my first posting was in Chhattisgarh. It was a huge eye-opener for me because that was the time that when I was first exposed to true grassroots level public healthcare system. Until then, my belief, generally everyone's belief has been that doctors work in hospitals, in clean, sterile hospital rooms, in surgical theaters where everything is set up for you. And that's how you save lives. For some reason, that was in my heart, and for most people, that's what people think. Basic grassroots level public health care and that you can save lives was something that was not really there in my head. So when I went to Chhattisgarh for the first time, working in the rural villages and in the forest there, that was truly an eye-opener for me. Distributing and treating patients with basic paracetamol, basic antimalarials, and the fact that just with those basic healthcare that you could actually save thousands of lives in very remote settings. Maybe not the privileged ones, but still human lives that otherwise had no access to healthcare. So since then, over the next 4 years, I had the privilege to work in many different settings for MSF and different projects. And today I'd like to talk to you a little bit about the work that we do. For doctors and nurses who choose to get into the humanitarian healthcare system today, the world is an incredibly dangerous place. In Yemen, for example, just in 2016, 4 of our hospitals were attacked. In Syria last year, 63 MSF hospitals, MSF-supported hospitals were bombed or shelled. 23 of our staff died in those places. Over the years, MSF has been able to work in some incredibly complex, violent situations because of our principles. We hold 3 principles very close to the work that we do. Those are the basis for all the work that we do. Neutrality, meaning that in any conflict setting that we are in, that we take no sides. Impartiality, meaning that we do not care about the patient that is coming to our clinics, regardless of their religion, regardless of their caste, regardless of their political or other affiliations. We continue to treat them as patients and nothing else. We have no other interest in them except seeing them as human beings and patients that deserve care. And independence, meaning that we do not accept money from governments, we do not accept money from special interest groups, and because of that, the majority of our funding comes from individual donors, students, grandmothers, individuals like you and me, and because we have that financial independence, we're able to go to some increasingly complex situations. One of the places that was really affected recently and that I want to talk about is Kunduz in Afghanistan. I believe many of you in this room have heard about the attack in Kunduz. This was a fully established, well-functioning, practically the only healthcare system that existed in Kunduz in Afghanistan. This facility was attacked last year and this is what the place looked like. And after the attack, where the entire functioning hospital was attacked by a gunship for almost 30 minutes continuously, deliberately attacked. The United States went on to describe it later as a mistake, as a collateral damage. But this is what the hospitals look like. Patients died on operation theaters. Patients died on hospital beds. People who ran out of the hospitals were continued to be shot down by gunships that were circling overhead for about 30 minutes. Following that, MSF demanded from the International Humanitarian Commission an independent investigation, clearly saying that this cannot be the new normal. We cannot accept and stand by and watch when humanitarian healthcare settings are affected and are targeted and when medical care comes under fire. We said that very loud and clear, our president in our address to the UN, that the doctor of your enemy is not your enemy and that even war has rules. This cannot be accepted, and the day when healthcare facilities in conflict zones start to become attacked, then the people who are most affected are the population, the innocent ones who are living there and who then have zero access to healthcare. So it is very important for MSF and other organizations there to continue to work in these places. MSF goes where no one else goes. We prefer to work in areas and pockets of exclusion where other actors are no longer willing to work or there is no other access to healthcare. We believe that everyone, every human being deserves access to quality healthcare available at a place close to them, and regardless of any of their affiliations or regardless of any of the conflicts that are going on. In 1999, in recognition of our work, MSF was awarded the Nobel Peace Prize. It was also in 1999 that MSF began to work in India. Today we work in about 8 states doing different aspects of healthcare: Kala-Azar, HIV, MDR, TB, HIV, Hep C, emergency obstetrics, malnutrition, mental health, dengue, and other febrile illnesses. In a year, we go on to deliver about 130,000 free treatments around India. And this is a bit that I want to speak to you about one of our projects in India. So, neglected tropical diseases, or NTDs, is something that, a set of diseases that the world has kind of forgotten. 1 in 6 people worldwide suffer from a disease that most people here have never heard of. Diseases like lymphatic filariasis, onchocerciasis, leishmaniasis, Chagas, leprosy, trachoma. These are diseases that affect billions of people around the world, yet classically NTDs are diseases that affect the lowest income groups. Because they affect the lowest income groups practically only in developing countries, what that means is that it's a vicious circle. So pharmaceutical companies no longer see the point of developing drugs or treating these conditions because it does not get them a profit. Corporate hospitals many times do not treat these diseases. But these are diseases that really, really affect the poorest of the poor. So in India last year, MSF handed over its Kala-Azar program in Bihar to the Bihar State Health Authorities after almost 8 years of working there. Kala-Azar, or visceral leishmaniasis as it is known, is one of the world's largest parasitic killers. It's actually the second largest parasitic killer in the world after malaria. And it's a disease that affects the poorest of the poor. In Bihar, for example, it's a disease that typically affects the Mahadalits, or people that are living in mud houses, because the disease is spread by the sandfly, which dwells on the mud walls of these houses. So what basically happens is that these people present to your clinic generally with persistent fever, enlarged liver, spleen, etc. And if it is left untreated, 100% of these patients eventually go on to die within 2 years. So the treatment for Kala-Azar in India typically used to be a drug called sodium stibogluconate. I believe many of you have heard of this drug, SSG. It's an incredibly toxic but painful drug from the 1940s. Yeah? Sadly today, even today in 21st century India, if you go to many hospitals in rural Bihar, you still see patients hooked on to SSG. And that's sad because it's an incredibly painful injection as you give it into the veins. It is painful, it's really toxic, and it's a drug that was from the 40s. And so, after some years, in the last decade, another drug came out to be introduced in the healthcare system, and that was amphotericin B. The problem with amphotericin B is that amphotericin B is also toxic, and it also requires that you give it for 15 days on alternate days, which means that these daily wage workers, these farmers, often end up being admitted into hospitals continuously for over 1 month. And because they're admitted for 1 month, they can no longer earn their living, and it completely messes up their entire economic livelihood. Msf began to work in Bihar in 2007, where we introduced a new drug called liposomal amphotericin B, or Ambizome. Ambizome was a revolutionary treatment because instead of the 1 month of treatment or the 15 alternate days of treatment, or instead of SSG, which was very toxic, Ambizome was a drug that required just a 2-hour infusion. So the patient would come to you, you would check the patient, examine, admit the patient, and infuse this drug for over 2 to 3 hours, and that showed incredibly good cure rates. So Msf began to work with Kala-Azar using Ambizome in Bihar since 2007. Working with the National Vector-Borne Disease Control Program and the Bihar State Health Authorities in the Hajipur Sadar Hospital, Msf went on over the next 6 years to treat over 12,000 of the poorest patients there for free. And based on the work that Msf did, last year the Indian government accepted Ambizome as the first-line treatment now for Kala-Azar. And today, in different states in India, in Bihar, in Jharkhand, and West Bengal, this has now become the first line of treatment. And it's a drug that is now continuing to change thousands of lives today. Although we handed over the Hajipur Kala-Azar project, we still continue to maintain a small presence there because now we're looking at another lethal combination. So this is the combination of people who are co-infected with HIV and Kala-Azar. And that's a deadly co-infection because when you have these two diseases together, it means the relapse rates are much higher, it means the drug responsiveness are much lesser, and these people require a much higher standard of care. So Msf continues to work in Hajipur today, focusing on HIV Kala-Azar co-infections. Moving on, emergency responses. Msf began in the 1970s as primarily a medical emergency organization. So responding to medical emergencies around the world is really at the heart of what Msf does. Globally, Msf has an impressive medical response capacity. Many of you are familiar with these pictures from the Ebola crisis. In the Ebola crisis that happened last year, Msf alone treated over 1/3 of all the patients. Over 10,000 patients of Ebola were admitted and treated at our Ebola treatment facilities in Guinea, in Liberia, and Sierra Leone. So we maintain an extensive emergency response capacity. Most Msf projects have really trained staff and pre-positioned resources to respond to emergencies. When you respond to emergencies day in and day out, every single year, you begin to innovate. One of the classic problems that we faced was that often you had an emergency that happened the next day and you had to immediately be present, but often the task of collecting all of the things that you required to respond to these emergencies in a standardized manner was a big problem. So Msf started to develop pre-packaged, ready-to-dispatch kits. These kits are of different specifications. They are emergency response, emergency healthcare kits, we have cholera kits, we have many different types of kits. So these kits pack everything that you would need to respond to specific emergencies into one single box that you can just put on a flight and fly it in for the next day. The size and the completeness of these kits are sometimes not really understood by a lot of people. For example, to work, let's suppose you had to work in a place where you had, say, 30,000 people displaced for 3 months. Typically, Msf would have some of these large kits, 3 kits which can respond to 10,000 people for 3 months. So these kids are already at our storage. We take them out, we fly them out, and we can start responding right from the next day. And that's something that has really revolutionized the logistics side of our response capacity. Recently, we started to use inflatable hospitals. And that's something as well that I would like to quickly talk about. So, inflatable hospitals, when you have natural calamities or disasters, typically you have your entire city's healthcare system pretty much wiped out. So what you need to respond to is you need to quickly set up field hospitals that can quickly be deployed and start treating hundreds of patients. So these Msf inflatable hospitals are modular plug-and-play units that you can quickly deploy in a span of a couple of days. Inflated out, and it contains over 100 beds, surgical units. They're all with air conditioning, with all the facilities that you would require to treat hundreds of these patients. The last time that I was involved in this was in Nepal, where we deployed an emergency inflatable hospital as well. So recently in Nepal, and that's something that I want to step into next. In Nepal, as most of you know, last year we had 2 major earthquakes. These were 2 earthquakes that happened in a span of a few days in April and in May of last year. I was one of the first responders from MSF to this emergency response. Nepal is a place that holds special place in my heart. I lived in Nepal for 6 years, and I remember the day after the earthquake, the next day I was on a flight. I landed in Kathmandu. And it was such immense chaos. Nobody knew where the epicenter was. Nobody knew which areas were the most affected. I remember landing in that complete confusion. We landed and we quickly realized that the city itself had not been affected. Kathmandu and the other areas around had not been affected. The areas that were most affected were remote, mountainous villages. They had been completely wiped out. The following day, me along with a colleague, we hired a helicopter because that was the only way to get up to the Himalayas and to see for ourselves the extent of the destruction that had occurred on these mountains. So I remember landing. So within a few hours, MSF teams had already started to respond from around the world. Teams from Netherlands, from Brussels, from Paris, from Kathmandu, from Bihar, from Tokyo. All these teams within a matter of a few hours had already started flying in aircraft filled with these kits, emergency response kits, inflatable hospitals, etc. MSF went on to sustain that response for about 6 months after that in Nepal. And I remember this was the scene at Barpak. Barpak was the epicenter of the earthquake. I remember flying in and landing at Barpak, and it was terrible. Bodies strewn everywhere, fractures all around. We were in a helicopter that could carry 3 people at the most. They were small helicopters. And it was crazy the amount of destruction that these communities had gone on to see. And the second earthquake, people slowly started to build their lives up from these earthquakes after the first quake had passed. And then on the 12th of May again, you had the second earthquake, and that instilled a lot of fear in people's minds. So people started to live outside in the communities for about weeks on end, staying under tents. MSF provided health care and supplied shelter and hygiene kits to thousands of these people, almost 7,000 to 12,000 people. We ran mobile helicopter clinics because that was the only way to get up to the mountains. And we set up an inflatable hospital that could treat surgically and orthopedic injuries that happened. The response that we had in Nepal was really something that still stays in my heart. I mean, the number of people that were affected, the complexity of responding to those, because you could not respond the typical way. There was no way to fly people out of the mountains. So we went in with helicopter mobile clinics, and that's how we treated a lot of people. Sadly, MSF also paid a big price for it. We lost 3 of our staff. Some of them who were very close colleagues, in a helicopter accident. And so we paid a big price for the work that we did. But this is the way that MSF responds to emergencies, and this is the way that we try to take healthcare to places where most people never actually have access to any healthcare. I'm running out of time, so I want to conclude. Most of us, doctors and nurses, take medicine because of a calling. Yeah? We believe that we want to try to make a difference. Most of us are here because we believe that we really want to change people's lives. Doctors are a profession that spends the best years of their youth in hospital classrooms and wards, studying the nuances of the human body. And in return for that, society gives them a lot of privileges and titles that they don't give anybody else. As doctors, society finds it perfectly acceptable for you to hear the most frightened stories of your patient that they will not tell anybody else. Society finds it perfectly acceptable for doctors to examine the most private parts of patients' bodies. Society finds it perfectly acceptable for us to have access to a lot of things about people's emotions and minds. What is all too often forgotten in the medical fraternity is that behind our statistics and our figures, behind the numbers that we see and behind our policies, behind our closed borders, behind all the barriers that we create, we forget that there are incredibly needy, anxious human beings whom we often forget to see. Being able to take healthcare to these people who are the most in need and being able to take it to them at a time when they need it the most, I think is something that I've had the privilege to see that in MSF. Hundreds of MSFers embodify it day in and day out, risking their lives, taking immense risks to deliver this healthcare to places that nobody else goes to. So taking healthcare to places that nobody else goes to, that's what MSF does, and it's been a humbling experience, and it's been an honor to work for MSF, and that's the work that we do. Thank you.
Very moving presentation, Dr. Mathew. We can take a few questions at this point.
Dr. Mathew, that was really humbling. My name is Vikram from GE Healthcare. If there's one thing that you would want the private sector to do for you, what would that be?
I think in the field of innovations, the private sector, especially in the laboratory sector, for example, has a huge part to play. Diagnostics. For example, when you look at Ebola, for example, it was sad that Ebola was not a new disease for mankind. It's a disease that we have known for over 40 years. The sad fact is, because Ebola was a disease that affects people who are not living in the developed world, it was a disease that nobody bothered to develop diagnostics for. So at the heart of the Ebola, at the peak of the Ebola response, it was a sad fact that we had no vaccines, we had no good diagnostic tools to respond to Ebola. And so being able to have the tools available at a price that is affordable for the humanitarian healthcare system, I think that's a big need, and that's something that the private industry can definitely undergo for.
Indeed, inspiring, Prince. I just had one question about MSF. Where does your talent pool come from? Is it a talent pool which is stable and works only with MSF? Or do you have an opportunity where I'm saying in an open forum that you can draw talent from existing corporate hospitals? Because you would be surprised that we work in different segments, but the calling is the same. People may not be willing to move to these areas permanently, but there is a huge talent pool which, if you talk to them, are willing to come, not in a reactive manner, in a proactive manner, and work for short periods. I know it is trying to get the best of both worlds. I would really like to talk to you, because this is something which I'm working with the team there. As to guys, you're in a corporate hospital, you're high-flying people, but would you be willing to go somewhere for a week? And the resounding answer always is yes. But where do I go? Who do I work with? How do I deliver? How do I answer my calling? So I would really like to talk to you about it, because there is if you just take all the corporate hospitals and you take every single physician, I can assure you 99% of them would say, yes, I'm willing to come and spend a week, 2 weeks with you. So there is a huge pool for MSF and other organizations. We should talk about this, because there is this passion, there is this commitment. People are willing to come. People are not willing to give it up completely because of their own reasons.
So perfect. So just to answer that in parts, so the talent pool for MSF comes from doctors and nurses around the world. They are not always fresh MBBS graduates. Many of them, like you, for example, are people who've worked many, many years in corporate settings and want to do a bit in between. I mean, a lot of the surgeons, a lot of the gynecologists, a lot of the plastic surgeons that are in our trauma care facilities are doctors who come in for short durations. For specialists like surgeons, plastic surgeons, and aesthetists, we offer between 6 weeks to 8 weeks contracts where people come and they work in war settings and are taken back. That said, a lot of the medical staff, there are an incredible number of Indian doctors and nurses that are working in other countries, not just in India. In India, we also have access to a large talent pool of educated doctors. For example, TB surgeons, for example, is a specialty that you don't really find in many other parts of the world. So for a lot of our pediatric TB facilities that we run in Central Asia, for example, many of the doctors come from India. So we have a recruitment center in Delhi where we are very happy to accept applications from people who want to come short-term, long-term. And the tie with corporate hospitals, this is something that we're starting to engage in for short ad hoc contracts. For example, now in Asansol, where we started our treatment facility on dengue and chikungunya, we required specialist help for internal medicine, for example. So one of our partners who agreed to help us for a 3-month rotation was the Manipal University, for example, who's collaborating with MSF now to detach some of their doctors for short durations to help us with that. So this is something that, yes, we can talk about, and I think it will be incredibly useful.
Superb. This is an area, I think, for innovation, inspiration.
Thank you.
Is there a question in the audience?
College. I want to understand how can medical students contribute while still in medical school to MSF? Is it possible?
For medical students per se, unfortunately, because of our regulations, we can only employ doctors who are fully registered and valid. So for this reason, yes, we do accept in a lot of our programs, like Chhattisgarh, for example, that I was talking about, or Asansol, where the work that we're doing is very grassroots public health. And for this, the doctors that are most useful for us would be fresh MBBS graduates looking to do their bit for public health care and being willing to work in some really difficult contexts. So yes, we accept a lot of medical graduates fresh out of college for a lot of our programs. I think there's a lot that we can do. I started myself I think on the 3rd day after I graduated from medical school, I started in Chhattisgarh. So there are a lot of opportunities for medical students.
Thank you, Dr. Mathew.
Thank you so much.
And may I request Mr. Ganesh Prasad, who is also one of our supporting partners from Genworth, the MD and CEO, to hand over the memento to Mr. Mathew, please.